Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent education grant from Crinetics Pharmaceuticals, Inc.
Thank you for joining us. I'm Krish Gednak. I am recently retired as an associate professor from Oregon Health and Sciences University after 20 plus years working in the Northwest Pituitary Center. And I'm currently the director of a postmaster's endocrine certificate program at Mount Marty University. So it's wonderful to be here. And my co-presenter, as introduced, is Dr. Kevin Ewan. He's professor of medicine, University of Arizona College of Medicine, also Creighton University School of Medicine, and he's the medical director of Barrow Pituitary Center, Barrow Neurological Institute in Phoenix, Arizona. So today we'll look at a patient journey. We'll also talk about the pathophysiology and clinical presentation of acromegaly, a little bit about diagnosing patients when they come to your clinic, and then some challenges in how to identify those patients, because it is a challenge. As we'll go through this, we'll talk more. And then we'll talk about treatment and what are the treatment updates currently. There's some new treatments and some patient cases. So thank you to Medscape for supporting this presentation, and Crinetics Pharmacology, a supporter of the program also. I'm going to introduce Jill Cisco. She is a community of acromegaly leader, and she will first of all present a little bit about her journey in acromegaly and the diagnosis and treatment.
Hi, my name is Jill Cisco, and I was diagnosed with acromegaly in 2005. In approximately 1992-93, I started having my first symptoms of acromegaly. Weight gain was the first pronounced symptom. I went on a 600-calorie diet and still continued to gain weight, and that told me something was very wrong. That's when I started going to physicians to try to seek out what was happening with me. But then after that, I started having gastrointestinal issues. I also started having breast issues. I went to OBGYNs because of loss of menses, and there was a whole plethora of symptoms that I was experiencing over the years that I probably should have been diagnosed much sooner. It shouldn't have taken, 12, 13 years prior to my diagnosis. But one thing that I had found is that you have to know about acromegaly in order to diagnose acromegaly. Living in rural America, my physicians didn't know about acromegaly to diagnose me properly. Instead, they were treating the symptoms. And that's something that I really think that we need to do better for patients with acromegaly, is identifying the symptoms, testing correctly, and getting these patients diagnosed sooner. Whenever I was diagnosed, I had approximately a 4-centimeter tumor, a macroadenoma. They try to catch these tumors before they hit 10 millimeters in order to provide the best surgical remission rates. And with my tumor so large, I went to a center of excellence for my surgical removal of my tumor. But shortly after, I found that I was still exhibiting symptoms of acromegaly, and I started on medications. So I have actively been treated for acromegaly since 2006 using a plethora of medications. I can finally say that I do feel like my condition is well controlled now, but it's because I am so compliant with my treatments. So some of the issues that I faced in getting my diagnosis is that I was told that I didn't look acromegalic enough. And that is very heartbreaking to me, because I certainly felt like I looked acromegalic enough. And you can see my before picture, and I've had no corrective surgery. That is the face of acromegaly. Physicians need to realize that, we don't want to have to get to what patients looked like, 80 or 100 years ago before they are diagnosed. Hopefully, we're doing better about diagnosing them sooner. My hardest part about the treatment journey was getting physicians to listen and understand, yes, I know that I'm having all these issues, but something is causing this. And trying to seek out the root cause of my disease. I've found throughout the years it's so much easier to treat the disease rather than to treat all of the individual symptoms. So one thing that I think doctors could do better by patients is to think outside of the box. I know in medical school that you're taught that if you hear hoofbeats, think about horses. But you have to realize there's a lot of zebras out there. And that is why I didn't get diagnosed sooner. No one thought about rare disease. But our patients truly do deserve the same care as what someone with a common disease has. Not just for the diagnosis, think outside of the box regarding their treatments. One of the ways that my endocrinologist has helped me over the years is thinking outside of the box. For instance, I went to him and I told him that I had excessive sweating, which is a symptom of acromegaly, and he prescribed prescription antiperspirant for me to put on my head while I was getting ready so that my head would no longer sweat. It was little things like that that really helped improve my quality of life with this disease. So within acromegaly, I've dealt with KOLs from around the world, and I've been told that acromegaly could be several different conditions all lobbed into one because, it causes a pituitary tumor that secretes excess growth hormone. So one of the places that I think that we're missing within acromegaly is the other subspecialties that could be diagnosing acromegaly, such as sleep specialist, or orthodontist, or ophthalmologist. These are all areas that patients could get an earlier diagnosis. I think one of the biggest things that we need within acromegaly is more research into how this disease works within the body, because patients have found that their symptoms don't match the biochemical measures to measure this disease, and we need to do better for our patients' quality of life.
So let's start with clinical presentation and pathophysiology. So as Jill just said, this is considered a rare disease. But unless you know to look for a rare disease, you don't expect ever to see it. And so we actually teach people that rare diseases, you may never see this in your practice. And so we don't look for it. So rare diseases are often rare diseases because we don't look deep enough. But the incidence of what we know at the moment, 0.38 per 100,000 people in the US, and the prevalence is 3 to 14 per 100,000. So, but it's probably a lot more common than that. And part of the big problem is this long trajectory to diagnosis. So some people are 6 to 10 years on average now, but up to 20 to 24 years for diagnosis. And there's a lot that happens in that interim. So it's very important that we diagnose these patients as early as possible, because the longer it takes to diagnose, the more concomitant disease these patients have and the more disability. And there's more. So let's just step back a little bit and look at the pathophysiology again. What is acromegaly? And acromegaly is really excess growth hormone. Growth hormone, releasing hormone, comes from the hypothalamus. There are vesicles in the hypothalamus that release this down this pituitary stalk and then into the anterior pituitary. The anterior pituitary then has cells called somatotrophs. So somatotrophs then respond to the GHRH by making growth hormone. So normally what happens is the growth hormone then literally goes and expands to most cells in the body. It attaches to receptors around the body to act somatically and for somatic growth and metabolic activity. However, normally this will shut itself off. So it has this nice little feedback mechanism. So once it attaches to the liver and the liver produces IGF-1, the IGF-1 will then act back into the hypothalamus to shut down the production or slow down the production of GHRH and also then the production of growth hormone. However, sometimes that growth hormone beats to its own drum and it autonomously makes growth hormone. When it autonomously makes growth hormone, then again, the body gets bombarded with growth hormone. And so you have all these somatic effects that are ongoing. There's a small incidence of GHRH production, there's overproduction from, for example, hypothalamic tumors or peripherally in carcinoid or pancreatic tumors. But again, it's a very small percentage. Extra pituitary sources, the pancreatic islet cells, lymphomas may produce GH, and it could be iatrogenic as well because we have a lot of sports competition and a lot of people are taking growth hormone to enhance their performance. Most of what we see is coming from this pituitary tumor, and the pituitary tumor is usually on the anterior pituitary. So very rarely do we see a carcinoma or a cancer. Most of these are benign tumors. And it's important to remind the patient that when we find a tumor, it's often benign. However, that does not mean that it doesn't secrete something. So pituitary carcinomas are very rare, extra pituitary tumors, familial syndromes also. So there is mutations that can be germline mutations that are passed through families. So we have excess growth hormone that produces this phenomenon or multiple symptoms of acromegaly. So about 17 in 100 people have been diagnosed with pituitary adenomas. But like I said, rest assured, it's not deadly. Okay, you will not die of your pituitary adenoma. Most of these are discovered on postmortem, but not because you die of it, just because it's there when you die, right? And so, again, what the next thing to determine is this an active hypersecreting tumor? Okay? About 2/3 of those pituitary adenomas may hypersecrete something. So what does that tell you? We're probably missing a lot of cases of acromegaly, okay? So there are a lot of people out there that really need to be treated. So we are finding more and more pituitary adenomas. And why are we doing that? Because in 1980, we only scanned heads for doing a CT scan. That was actually also before we developed the MRI, but about 3 million a year in 1980. And now anytime somebody has a bump on the head, has a new onset headache, we do a CT scan, right? And so now this is a little bit dated even. 2006, it was 62 million. 2023, we're up to 93 million a year in the US. So we are discovering a lot more tumors. Also, in terms of MRI, we are now discovering up to 22% more than what we were discovering years ago. So MRIs we do for solid tumors, and those new onset headaches, particularly over the age of 50, should be scanned because that's a high risk period for people with acromegaly as well. So new onset headaches, don't forget, over the age of 50, that person should have an MRI. So we talked about how common these acromegaly tumors are, and really they're only about 13. I've seen up to 17 to 18%. Some people say 30%. I think maybe, again, we're underdiagnosing, so perhaps that number is a lot higher, but most of what we see in terms of pituitary adenomas are non-functional or prolactinomas. So prolactinomas can also secrete growth hormone. So they can co-secrete. So if you see somebody with a prolactinoma, then we should also be looking for acromegaly and testing for acromegaly. So acromegaly overall incidence is 10 new cases per million under this current way of identifying patients that we have now. Overall prevalence, 70 to 80 cases per million per year. So what are we looking for? The risk factors, of course, of anybody with diseases such as MEN1, MEN4, Carney complex, FIPA, which is a familial isolated pituitary adenomas, and McCune-Albright syndrome. So anybody with those syndromes should also be tested for growth hormone excess. Ages between 40 and 60 is common presentation. So we have some very aggressive cases that are seen in early adulthood and usually young males. So be cautious of a young male who presents with a new onset headache. Sex, both sexes are affected fairly equally. Some papers will say females a little bit more than males, but generally speaking, it's equal. So when we talk about acral enlargement, patients present with a growth of hands and feet. But it's often not the symptom that they will tell a provider because they don't think that's a medical symptom. So their rings don't fit, their shoes don't fit anymore, but they often will associate that with just plain getting older. So it's an important indicator. If somebody walks into your office and says, oh yeah, well, my foot size changed or my ring size changed, that should be ringing bells. So jaw protrusion, as the disease progresses, then you see this enlargement of the lower jaw, right? You also see spacing in the teeth. We should see more patients referred from orthodontists, from dentists. However, we still have to get that message out because it's not as common. Also tongue enlargement, again, these are later symptoms. Cardiac hypertrophy, hypertension, skin tags, sweating, hyperhidrosis, as Jill was talking about, diabetes because it affects the liver then increases the glucose, sleep apnea, obstruction from soft tissue that is enlarging all over the body, and osteoarthritis as the joints then become inflamed and then become damaged. So as you see on the right-hand side here, the progression of this lady in A, this is her in youth. This is actually one of my patients on the right in later years. She's actually now very well controlled, but she really doesn't have some very severe features and never did of what we think of acromegaly when we think of Andre the Giant, for example. That's a very late case of acromegaly. These are very slowly progressive diseases. So you see the hands in B, the larger hand is the acromegaly hand. So you see the splaying of the fingers. If you have a handshake with your patient and they've got a really soft, doughy hand, look and see, what's the hand look like? Ask the question, do you wear a ring, or have you ever worn a ring, and why don't you wear a ring now? Okay, particularly for females, but also for males. Skin tags are common. Acanthosis nigricans is also common, particularly when patients develop diabetes. So, as I said, headaches are often the first presenting symptom that a patient comes to the office with. I think there's something like 80% of patients, their first visit is because they have a headache to their primary care provider. So headaches often are a lead-in, but acral enlargement, the enlargement of hands and feet, the facial changes, particularly broadening of the nose, the jaw, they're all later symptoms. But if somebody presents with a headache and then they have multiple symptoms like it's listed underneath, carpal tunnel, diabetes, if they have poor libido, if they have hypertension, we tend to treat these symptoms individually and not look behind what's happening, as Jill was saying. We don't look for the reason why there's multiple symptoms. So you get somebody with multiple symptoms like this, ask the question. And one of the big questions to ask is, any change in your hands and feet? Any gaps between your teeth? So the reason why we want to do this is because they're longevity is at risk. So these patients die early. And they die early the higher their concentration of growth hormone is. So when you look at this graph, if their growth hormone is less than 1, or it's controlled to less than 1, then they have a normal lifespan according to the rest of the population, right? However, the higher that growth hormone is, the higher the risk of early death. So we want to diagnose these people early. So we have gotten better, right? Now the mortality risk is only twice that of the general population. It was about 10 years ago or greater, 4 times. And you see on the right here, these graphs in all patients, we have decreased that to twice the normal population, still a little higher in men than it is in women. The reason for this is delayed diagnosis. We have to find these people early. We have to ask the question early. So look at the concomitant diseases, because they are what drives the higher mortality in this population, and the higher concomitant disease and the worse quality of life, as Jill was discussing. So what is the risk? They have a higher risk of cancers. They have a higher risk, 3 times higher risk of leukemia, lymphoma, ovarian cancer, breast cancer, lung cancer, prostate cancer. But they also have earlier onset, again, of those diseases. So anywhere between 3.2 and 7.2 years for ovarian cancer, that's early. So these patients, again, if you're finding a patient that's presenting earlier than expected with a cancer, ask the question. We have to cure the disease as well. We have to cure the acromegaly, or we put into a remission. We don't cure it per se. So, and how to diagnose these patients? Okay, so first of all is clinical suspicion. You have to have a suspicion that this patient may have acromegaly to then do an IGF-1, an insulin growth factor 1. So that is a fairly cheap test. A lot of states allow the patient actually to order their own test, so they can walk into a lab. And what I'm finding now is a lot of patients will come to me with their analysis that says, I've got these symptoms, and guess what? I want an IGF-1 because that's what's going to diagnose my acromegaly. So they're often right. So a suspicion, get an IGF-1. The latest growth hormone consensus was just published in 2025. I think it was August. And they recommend that if the IGF-1 is greater than 1.3, the upper limit of normal, that is actually diagnostic for acromegaly. So 1.3, the upper limit of normal, is an important thing to remember. So if it's elevated, ask the question. If it's borderline, then what we would do is we would send the patient for an oral glucose tolerance test. 75 grams of that nasty tasting orange stuff. And then we measure growth hormone every half an hour. We measure that. If it's elevated, and again, we'll talk about that cutoff in just a second, then it confirms acromegaly. We would then probably go to an MRI. But what I'm finding is the patient often is diagnosed with an MRI, and then they come in for testing to figure out whether, in fact, they have some hypersecretory tumor. So diagnostic IGF-1, first of all. Secondly, if it's questionable, do an oral glucose tolerance test. We don't do insulin tolerance tests very often because it's very labor intensive, and you literally have to drop the patient's blood glucose to the point where they are right at the point of death and they feel like it. So it's not a very pleasant test. Why don't we do a growth hormone itself? Why can't we just send them to the lab and get a growth hormone? The reason is because it's pulsatile, and its highest amplitude pulses are right after you go to sleep at night. It's in slow wave sleep that pulse is the highest amplitude. So you have to be very lucky to catch it during the day at its highest level. So it doesn't live very long in the blood. So in other words, its half-life is very short. But IGF-1 can be 15 to 17 hours. So you can measure it any time. And it is usually a one-to-one relationship between IGF-1 and growth hormone. So it's really important, again, to get your IGF-1. And greater than 1.3, remember, is diagnostic. So we can do a serial measurement every half an hour for a couple of hours of growth hormone and see if we can catch a high level. Again, there's risk to that. The other concern is the IGF-1 assay isn't always as reliable, and it's very different in very different labs. And so I think important to remember to do your IGF-1 as you're testing a patient in the same lab so that you get the same assay. So the diagnostic criteria has changed over the years. It was 5 nanograms per mil, and now we're down to the most accurate is 0.4 nanograms per mil, and that was from the Acromegaly consensus group that just met and published in August. However, the Endocrine Society says 1 nanogram per mil after testing is diagnostic, and most labs will look at the 1 nanogram per mil cutoff. So if they're above that on OGTT, then that's diagnostic for acromegaly. So challenges in identifying acromegaly, it's insidious, and it's the same as so many other diseases that come into your office. But remember, multiple diseases, multiple signs and symptoms, diabetes, hypertension, you need to look and ask the question. We need to ask what their family history is. Is there any chance that this is a germline type diagnosis? So GH assay can be very challenging. The cutoff can be challenging. And again, refer a patient if you're concerned about this patient having acromegaly to your local endocrinologist or endocrine team. IGF-1 is tricky, but it's the best we have. So ask for an IGF-1, get the patient to do an IGF-1. So with that, I'd like to turn over to Dr. Ewan to talk about the treatment.
All right. Thank you. So now that you've all thought about acromegaly, now you have a patient sitting in front of you, your diagnosis is confirmed. What do you do next? Which is my role here, is to talk to you a little bit about the treatment options available. So this is the consensus algorithm, essentially giving you a bird's eye view of what should be done or could be done when you face with a patient with acromegaly. Surgery is the first line following confirmation of diagnosis. Now, obviously, surgery can be successful, but not in all cases. So in situations where surgery is not successful, in other words, if the tumor is mostly removed but not completely removed for a variety of reasons, it could well be that the tumor is too big and maybe the surgeon is not able to access the whole part of the tumor because it's in location that is hard to get to for a variety of reasons. Then you're left with a patient who still continues to have disease. We call it persistent disease. And in this situation, then you would consider medical therapy, and there are several choices you can see there that you could consider, but which I will go through in detail. So we kind of try and break it down, at least in this consensus guidelines, into mild, moderate, and severe. So in mild cases, sometimes Acromegaly is recommended. It's an oral medication. You take it twice a week. It's generally used for patients with high prolactin levels, like prolactinomas. But it's also used not infrequently in patients with acromegaly. The only problem is that it's not FDA approved, so it's used essentially as an off-label use. If you have tumors that are visible on the MRI that have characteristic features, for example, hypointense T2 signals, high SSTR2 expression, you may consider using an injectable SRL, injectable somatostatin receptor ligand. More recently, there are oral versions available, so that is another option. And finally, if you have a patient who not only has acromegaly but also has concurrent diabetes, then and with no evidence of tumor that you can see on post-op MRI, pegvisomant could be an option, which is a growth hormone receptor antagonist, which most of you chose. So it's not entirely wrong, but you kind of want to choose the right option for the right patient, because obviously it works best for the patient as well. And the idea is to normalize the IGF-1 and to control growth hormone levels, because if you don't, then you run the risk, as Chris has shown you earlier in that figure, that if you don't control their growth hormone despite treatment, they still run a risk of having their lifespan affected as well. So you can see here the main goal is to normalize IGF-1, but again, it really depends on the situation. So if the patient continues to have elevated IGF-1, which is the marker that we use, i.e. inadequate disease control, we either can consider radiation or we can consider adding another option, another treatment. So we call it combination treatment. In this case, you could combine it with pegvisomant or pasireotide. And for those patients, very rarely who have very aggressive tumors, a chemotherapy drug called temozolomide is also used. Thankfully, not very often, because these tumors generally are not super aggressive. But the bottom line is that it really depends on the situation. And in this situation, more often than not, it's treated by an experienced endocrinologist, because you kind of need to know which options to use for the appropriate patient. Either you add a medication, or you switch a medication, or you consider radiation, or you consider all the above, medication followed by radiation. Again, like I said to you, primary goal is to normalize IGF-1, because that's what the data shows. If you don't, patients' morbidity and mortality increases. But not also forgetting that quality of life on these patients is also extremely an important factor for them. Why? Because even with normalization of IGF-1, they continue to have symptoms. Some of these patients, because don't forget, these patients have had the disease for a long time. That's why we emphasize on early diagnosis, because when they have had disease for a long time, their joints, their muscles, their bones can grow and can also develop complications which do not reverse despite normalization of IGF-1. So they may continue to have symptoms such as headaches, joint pains, sweats. So not only you're also controlling the IGF-1, you need to also address some of these symptoms, as what Jill has mentioned to you earlier, because it's extremely important to improve their quality of life. Like I said earlier, 3 key aspects of treatment options. You have surgery as the first line. So if you find a tumor in an acromegaly patient, you refer them to preferably an experienced pituitary surgeon. Medical management is generally reserved as second line. In other words, surgery hasn't caused disease remission, or patient continues to have disease. That's when you consider medical therapy. Now, in rare occasions, medical therapy can be considered before surgery. In those circumstances, it would be patients who are not good surgical candidates for a variety of reasons. They are too sick, they have other health issues, they have severe hypertension, they have blood clots, they're not good surgical candidates. Perhaps medications can be used before surgery. But generally, most of the time, surgery is the first line. Radiation is the third line option, and sometimes, understandably, especially in younger patients, they may not necessarily want radiation, because there's a theoretical risk that it could actually affect their brain function as they get older. So we generally reserve radiation as a third line option, and also particularly for those patients where after they've had surgery, there's still some residual tumor seen in the MRI that could not be removed completely by the surgeon, and that's when radiation could be considered at that time point. But even with radiation, you still need to consider medications, because radiation doesn't work immediately. So you radiate the patient, you still need to consider medications, because radiation takes generally about a year, 2 years, sometimes up to 3 years to work. So medications could be used as bridge therapy. So here is a slide from my colleague Monica Godella from Brazil, where she looked at over almost 200 of her patients, and she classified them as microadenomas, small tumors, versus macros, which is big tumors. And you can see that remission rates after surgery is generally better for those with small tumors. No surprises there. The smaller the tumor, the easier it is for the surgeon to remove this tumor in its entirety. So about 2/3 of these patients in remission is induced, and about just under half of macroadenomas, remission is actually achieved. So bit better results for microadenomas. What about the data for second surgery? So for example, in a patient who has had first surgery and there's still residual tumor there, then you see here, these are smaller numbers obviously, but certainly for microadenomas, if you don't get all of it out the first time, in smaller tumors, more likely than not, you could get most of it out second time. Obviously, again, I emphasize in the hands of an experienced surgeon. But again, it's a little bit tougher, and you see the numbers are a lot smaller if they're macroadenomas, and the reason being, these tumors could be invasive or it could be in a location where the surgeon may not be able to access, hence the lower numbers. What do you do after surgery? So this is what we like to see after surgery. Just like everything else, these patients present with high IGF-1 levels, high growth hormone levels. So post-operatively, you want to see these levels drop. Generally, in some patients, it takes time for it to drop, sometimes up to 12 weeks. So if after week 6, you find that the IGF-1 is still a little bit elevated, don't worry, because there are some slow responders. So we generally say give the patient at least 3 months or so to see what their IGF and growth hormone levels are. And if by then, if they continue to be elevated, most likely they're probably not in remission. Another way to assess post-operative success is to do what we call, again, an OGTT, as what Chris alluded to, where you give them the glucose drink and then you measure growth hormone levels every 30 minutes on 5 occasions. And the idea is to see that high levels of glucose will suppress growth hormone to less than 1 nanogram per ml. More recently, 0.4, depending on the more sensitive growth hormone assays that you're using. Then we also recommend post-op MRIs, again, not to be done too quickly after surgery. Generally, we would say, after about 12 weeks or so, to see how much is left behind. So you want a surgeon, especially, they want to see what's left behind after they've taken out the tumor. Occasionally, you may do a random growth hormone 2 weeks after the surgery compared to pre-op. But like I said, the rule of thumb is usually to see what these levels are after 12 weeks. And the aim is to see that the IGF-1 is within the normal range. Now, beyond 12 weeks, if the IGF-1 is still elevated, patient still has symptoms, at that point in time, that's where second-line treatment comes in, which is medical therapy. So what types of medical therapy that we have available at our disposal? Currently, they're split into 3 general groups. You have Group 1, which is the dopamine agonist. Again, that is not FDA approved. If you're using it off-label. The most commonly used category of medications is the SRL, the somatostatin receptor ligand, of which there are several. You can see on the list on your right. There's first and second generations. We've often in the past used the injectable ones. They are typically administered every 4 weeks, octreotide, lanreotide, and the second generation pasireotide. More recently, there's 2 new oral versions that have become available. You have the oral octreotide, and the routine has become FDA approved, so it's become available. It's an oral version that you take every day, once a day. And then lastly, you have the growth hormone receptor antagonist, pegvisomant, which is an injection. Now, granted, these medications are not cheap, especially pegvisomant and the injectable SRLs. And also the oral ones. So that needs to be factored in. What's the success rate for these medications upon treatment? You can see that the injectable SRLs I had mentioned to you earlier, the efficacy rate is roughly just over half, about 55%. In other words, you still have 45% where patients may or may not respond. So you could have the partial controls, and you can also have patients who are resistant. And also, just like any medication, even if they respond well, they may not tolerate well. So even a patient who does well, biochemically, they respond well, they may not tolerate because they may have side effects. So that's another factor to take into consideration. But generally, 55% response rates for injectable SRLs. Now, the advantage of injectable SRLs is that it is an injectable once every 4 weeks. So patients get their injections for 27 days or so, roughly, they can forget about it, which is kind of nice, especially for those who do not have to deal with it every day. There's some data to suggest that it may also shrink the tumor over a period of time, although the data is not very solid, but certainly by the way the drug works, there is a theoretical possibility that it could do that. The disadvantage is the fact that it's an injectable and the needles are actually quite large. They're not like insulin injections. They're actually quite big. So it can be quite painful at the site of injections. There's also GI issues because somatostatin also works in the gut. It can actually cause GI upset, sometimes diarrhea and nausea as well. And also it can also increase the risk of gallstones. So one has to be mindful of that, especially for those patients who are susceptible to gallstones. Oral octreotide was approved about 3-4 years ago. It is the oral version of the injectable. It's generally taken twice a day for 1 hour before food or 2 hours after food. So it's very, very dependent on food. You have to take it away from food. The efficacy is roughly about the same as injectable SRLs, about 58%, based on the normalization of IGF-1. Advantages is that it's not an injection, so you take it like any other medication. The problem is you have to take it twice a day, and you have to be very mindful of the timing of when you take this medication in relation to your meals. Because it's shorter acting, that's why it's taken twice a day. It's a plus and a minus. Shorter acting means you have to take it more frequently, but then shorter acting means that if you do get side effects, it's not going to be hanging around for very long. Disadvantage, like I said to you, the food issue, the compliance, because don't forget, these patients are also on many other medications. So when they're on many other medications, they have to remember to take all the other medications plus this medication and be mindful of the timing that they take it in relation to their food. And sometimes there are medications that can interfere with the absorption, particularly drugs that can alter gastric pH, such as the proton pump inhibitors. So you have to be mindful of that because it can affect the absorption of the medication. Cabergoline, in my opinion, is the least effective. You can see it's only up to a third, roughly, in terms of efficacy. It's generally very well tolerated. It's also relatively inexpensive. It's an oral administration, but like I said, it's the least potent of the options that we have. And it's not FDA approved. And also, if you use it long term, especially in high doses, one has to be mindful of cardiac valve abnormalities. There's also treatment escape sometimes where the patient responds and then they lose the control and then, the disease could come back and that could be a problem. And finally, rarely there's also this issue of impulse control disorders because cabergoline affects the dopamine levels in your brain, so it affects sometimes the behavior of patients. It's extremely rare. It can cause them to develop impulse control behaviors like excessive gambling, excessive spending, compulsion, things like that. Again, it's not common, but it's something that you need to be mindful of. Pasireotide long-acting is the second generation SRL. Again, the efficacy is roughly about the same in the 50s. The advantage, I guess, is that there's some data to suggest it's more effective than the first generation in tumor shrinkage. But the problem with pasireotide is that because it also interacts with other somatostatin receptors, which also is found in the pancreas, it can cause glucose intolerance. So about a third to about 40% of these patients who go on this medication can develop hyperglycemia or diabetes, which obviously is not what patients want to hear. And you don't give the patient the medication and then you tell them, hey, there's about a third of a chance that you may get diabetes. So that's not an easy sell, but it works in the right patient. And I have a few patients where it's actually quite effective and seem to be controlling the disease very well. Pegvisomant, it's a little bit better. It's in the 60s, and if you actually give the dose high enough, the efficacy rate could go up to as high as in the 90s in previous randomized prospective controlled studies. The thing with this medication is that it blocks the effects of growth hormone at the level of the receptor. So it does not change the tumor size, it just blocks the actions, which means that you can only measure IGF-1 because if you measure growth hormone levels will be high because you're blocking the growth hormone at the level of the receptor. It's generally well tolerated, and the other positive or advantage of pegvisomant is that it also, because it blocks the effects of growth hormone at the level of the receptor, it actually helps the glucose metabolism in these patients. So for diabetic patients, it actually helps to a certain extent in regulating their blood sugars as well. Problem is that it's licensed to be used every day, so it's an injectable that patients have to remember to give themselves, and one has to be mindful that it could actually aggravate the liver as well and cause liver dysfunction. Finally, this is the newest kid in the block, paltusotine, which was approved. We have one new medication now. It's an oral medication. Like I said, you have to take it once a day, fasting, first thing in the morning, 1 hour before food. It's relatively longer acting than oral octreotide, which allows it to be administered once a day instead of twice a day. It's generally well tolerated. And I guess the advantage and also the disadvantage I've put down there, oral can be an advantage or a disadvantage. Why? Well, if it's an advantage because you're not having to give the injections. The disadvantage is that if you take an oral medication, you need to remember to take it every day. And that's where some patients may not be able to deal with that because they have all the other medications as well. So it's an added responsibility that they have to remember to take it. And the timing, which is again, first thing in the morning, is important. The side effect profile is actually very similar. Again, GI and perhaps also gallstones. So again, we have to counsel the patient to report back to us if they do experience some of these symptoms. These are very newly published results. They call the studies Pathfinder 1 and Pathfinder 2. Pathfinder 1 is where patients who were previously controlled on injectable SRLs were switched over to paltusotine. You can see over about 83% of these patients responded to normalization of IGF-1. Pathfinder 2 are those patients who were not receiving any medical treatment in the past or who have had washout, a little bit of a lower response, but still roughly about 56% compared to placebo. So again, very impressive data. It's taken through the orally and is intrinsically gut permeable, which is why it's taken once a day. Treatment monitoring. Once you're treated the patient, you obviously monitor the IGF-1. Though for those patients who are taking injections, you check the IGF-1s about a week or so before the next injection. You check for symptom control because, like I said, symptom control is a key aspect in good management for these patients, as well as you make sure that the patients are not experiencing any adverse effects. About a year after the surgery, we generally perform another MRI to assess for tumor recurrence, cardiovascular disease, degenerative joint disease, malignancies, and sleep apnea. So these are all things that we need to keep an eye on very closely for these patients. In terms of quality of life, again, we find that they are very symptomatic most of the time. So it's very important that we do a good job in making sure that their quality of life is maintained, ensuring that the breakthrough symptoms are addressed. We may sometimes switch them from injectables to the oral paltusotine, for example, if they develop breakthrough symptoms during the injections. Many of them also do feel emotionally burdened, both not only emotionally but treatment burden, and therefore psychological assessment and also perhaps also evaluation and treatment is important for these patients. Radiation, again, I'm not going to dwell too long about it. It's the third-line treatment, but it's reserved generally for those with persistent or recurrence of disease.
So therapies in development, there's some that are in phase 3 trials, the CAM209, that's a subcutaneous injection of octreotide. Again, that's a long-acting. There are lanreotide, another octreotide injection that's also in process, and a GH receptor antagonist. So let's watch this space because there are more in development. And octreotide was found to be superior to placebo. The octreotide sub-Q, 72% of patients responded in a random controlled trial versus 37 placebo. And again, when we noticed over the 52 weeks and when patients were switched from the placebo back to the octreotide sub-Q, they actually regained the standard of care of 94% of efficacy. So it's promising in terms of what's to come. So it's not approved at this point in time. Case examples: 25-year-old man, weight gain of 100 pounds. He's change of shape of jaw. He bites his tongue when he's eating. He's sweating a lot. He's got oily skin. Shoe sizes increase. Ring sizes increase. He's got carpal tunnel syndrome. He's fatigued. He's got knee pain, joint pain, headaches. His libido is pretty good though. So his labs, glucose, a little bit elevated of 160, but it's still below 200. Prolactins, borderline, 17.7, a little bit elevated. But his GH is 26.2, less than 3 nanograms per mil is the lab standard. IGF-1 was 1,569, so clearly this man has acromegaly. Here's his MRI. You can see that tumor in the middle there with the bulk on the right side of the sella, but very big tumor. Okay, patient resources.
So these are patient organizations that I've listed here that show that patients can go there to seek more information. So these are kind of really good information that they can find out more, because many of these patients, given the disease is rare, they do feel kind of alone, and they need some help and more support. And this is where you find these patient organizations that are helpful for these patients, which we provide them to go onto the website to look into. There's patient tools where they can journal their symptoms in a diary. When they bring, and they can bring their diary for them to be seen, and when you're seeing them in clinic, and that's what we look at to see the frequency of their symptoms as well. So these are some of the resources. And then the symptom diary generally comprises of several types of symptoms. You can see question Q1 to Q7 is really the core symptoms, and then there's some symptoms asking about memory and sleep. So again, these reported outcomes are tools to generally help you and also the patient to track the symptomatology, because they are generally very subjective, and this is a way of kind of giving the patients some degree of objectivity of how their symptoms are and how to compare whether there's any changes over time or not. Importantly, there are several centers of excellence in the country, in several cities. It's a multidisciplinary team approach, as you can imagine, because there's so many organs that are being affected, because growth hormone receptors are found everywhere. So all these centers are equipped with these subspecialization, where we have team meetings to discuss about the best option and the best therapies for this patient. And it's obviously shown that in studies that patients do better when they are offered a multidisciplinary team care approach. So conclusion, a high index of suspicion and prompt diagnosis is important to prevent the reversible comorbidities. We do have current medical treatments, but they're generally second line behind, first line being behind surgery. And the whole point is the whole objective is to improve their symptoms, normalize their IGF-1s, and reduce the possibility of tumor growth. There's new treatments in the pipeline that are coming through, and that's very exciting. But however, we still need to do a better job, particularly primary care providers who are seeing them, to diagnose them earlier, because by doing so, you can reduce the possibility of these patients developing more comorbidities and reducing the severity, so we can address them sooner. Sustained adherence requires tailored patient and family education. And also, I think a lot of education needs to be imparted to these patients because of the importance of adhering to their medications. And finally, we have emerging therapies that hopefully can improve their quality of life and reduce the comorbidities of these patients and hopefully improve their mortality rates.
Excellent. Kevin and Christine, thank you so much.